Today we will continue the previous presentation, the rest part of respiration. This portion has been already been given in the first video, so I'll be not repeating this. This was the basic mechanism of respiration, if you can recall. And so in the continuation of previous presentation, I'd like to show you the interpleural and intraalveolar pressure and volume changes during the different phase of respiration. This diagram has taken from Guyton. So in this picture or diagram, the pressure has been presented in centimeter of water. In inspiration, you can see that the intrapleural pressure decreased from minus 5 centimeter of water to about minus 7.5 centimeter of water, and during expiration that reverse, that is the interpleural pressure increases from minus 7.5 centimeter of water to minus 5 centimeter of water. And in case of intraalveolar pressure, when there is no respiration, there is no pressure difference between the alveoli and the environment, so the intraalveolar pressure is regarded as 0, but during inspiration it becomes minus 1 during inspiration, and that's how, as the atmospheric pressure has increased, or the intraalveolar pressure has now decreased below the atmospheric pressure, so the air will be entering from atmosphere to alveolus, and in case of expiration the intraalveolar pressure increases from minus 1 centimeter of water to plus 1 centimeter of water, or plus 1. That means the difference in the intraalveolar pressure has been increased by 1 centimeter of water from the atmospheric pressure. So that alveolar pressure is now increased from atmospheric pressure, so the air will be entering from alveolus to the atmosphere, and the pressure difference between the intrapleural pressure and intraalveolar pressure, this pressure is called the transpulmonary pressure. And this is a diagram to show the volume changes. That means how much air will be entering into our lungs during quiet respiration. During inspiration, if we inspire quietly, we inhale about 0.5 liter or 500 ml of air, and during expiration 500 ml of air is expired again, and this is called tidal volume of air. That is the amount of air that we inhale or exhale during a quiet respiration. Now comes the pulmonary ventilation. As you can see, the total amount of new air that will reaching the respiratory passage in each minute, it is called the pulmonary ventilation. So if we can calculate that how much respiration is taking place per minute, that is our respiratory rate, and if we can multiply this with the tidal volume, that is the amount of air that we are inhaling or exhaling during a quiet respiration, that will be our pulmonary ventilation. Normal respiratory rate is about 12 per minute in average, and tidal volume is about 500 ml, so the pulmonary ventilation amount will be 6000 ml or 6 liter per minute. Now comes to the alveolar ventilation. We have previously discussed that all the air that we inspire doesn't reach to our respiratory passages or where the actual gaseous exchange takes place. 150 ml of air remains in the dead space that cannot reach to the respiratory zone. So in calculation of alveolar ventilation, which is the rate at which the new air reaches the gas exchange areas or the respiratory zone, is called alveolar ventilation. So we have to multiply the respiratory rate with the amount that will be reaching only to the gas exchange areas, that we have to minus the dead space volume of air from the tidal volume, and normally in conducting zone 150 ml of inspired air remains, so that will be not reaching to our respiratory zone, so we have to minus it from the tidal volume, and that's how the alveolar ventilation rate comes to 4200 ml or 4.2 liter per minute. So the difference between the pulmonary and alveolar ventilation is that the pulmonary ventilation calculates the whole amount of air that will be reaching in every respiration, quiet respiration or quiet inspiration. But alveolar ventilation calculates only the amount of air that will be reaching in our gas exchange areas, and so that alveolar ventilation is dead space dependent, while pulmonary ventilation is not dependent on dead space. Now, the elastic recoil tendency or collapsing tendency of lungs. I have previously discussed in previous slide that the alveolus are elastic structure, and like every other elastic structure, they have also the tendency to return to their original state, and that is, the lungs or the alveolus of lungs has a strong tendency to collapse and pull air from the chest wall because they are elastic structure. So this is called the elastic recoil tendency or collapsing tendency of lungs. So if the alveolus get completely collapsed, it will create a havoc in our respiratory system. So we have to prevent it, and there is some natural factors which prevents our lungs or alveoli from collapsing, that is the negative interpleural pressure which held the lung in their position. Now comes the question, why the interpleural pressure is always negative, why it cannot be positive? Because there is some lymphatics that gives a suctioning action in the interpleural space, which suctions the lymphatics from this interpleural space and creates a negative interpleural pressure. If in any instances these lymphatics cannot work or perform their functions normally, and or any instances when there will be creation of a positive interpleural pressure, so the lungs will be get collapsed, because this negative interpleural pressure is necessary for the expansion of the alveoli, because we have previously discussed that interpleural pressure means the pressure in the interpleural space, that is between the visceral layer of pleura and parietal pleura. Visceral pleura attached just to the alveoli and parietal pleura is attached to the chest cavity. So if the alveoli has to be expanded or they have to remain expanded, so the pressure outside of the alveoli must have to be low than the pressure inside the alveoli or than the interalveolar pressure, so that they can be expanded. If the opposite effect occurs, that means if the interpleural pressure, if any instances become positive, that will compress the alveoli, and as the alveoli are already a elastic structure, so with that compression they will just collapsed, okay, because of the compression. So that is prevented by the negative interpleural pressure, which makes the alveoli possible to be expanded. And then again, one important factor that prevents the collapsing tendency of alveoli or lung is the residual volume of air in the alveoli. That is the volume of air that will be always remain in the alveoli with the most maximum effort or expiratory effort. We cannot expire this amount of air. If we give our maximum effort, even though we will not be able to expire this amount of air will be always remaining in the alveoli. If we compare the alveoli with a balloon-like structure, they are actually balloon-like structure. So if we can imagine a balloon, if the all of the air comes out of the balloon will be collapsed. So this is the same case in case of alveoli. To prevent them from collapsing, we must have to keep some amount of air in the balloon or the alveoli. So this air is called residual volume of air. And another important factor is the surfactant that reduce the surface tension of fluid lining the alveoli. Surface tension is the tension or the attraction forces between the molecules of the fluid. We have already learned about it in our physics. This surface tension of the fluid or the attraction forces between the molecules of the fluid always attracts them towards one another, so they have the tendency to contract the structure over which surface they are present. If our alveolus are lined by a thin layer of fluid, it will be discussed later in the structure of respiratory membrane or the layers of respiratory membrane. You will see that there is a layer of fluid and surfactant in the alveolus. This fluid layer actually covers the alveoli to prevent them from getting dry. So this fluid layer or the molecules of the fluid has a strong tendency to attract them towards one another. So while doing this, they also have the tendency to collapse or to contract the alveoli. So we have to prevent it if we want to keep the alveoli from prevent the alveoli from collapsing. So this surface tension of the fluid or attraction forces between the molecules of the fluid is reduced by the surfactant, and surfactant is discussed later. It is a surface active agent of the alveoli, and it composes of phospholipid proteins, calcium ions, and different types of other molecules. The percentage is given here. And as we all know that dipalmityl phosphatidyl or phosphatidyl glycerol or phospholipid, these are lipid soluble substances. So lipid soluble substances will not dissolve in the water content. So because of this lipid portion of the surfactant, actually they reduce the surface tension of the fluid lining the alveoli, because the water soluble portion or the protein or carbohydrate portion of the surfactant that dissolve in the fluid layer of the alveoli easily, but the lipid portion of the surfactant doesn't dissolve in the fluid portions of the alveoli, and that's how they creates a barrier between the attraction forces between the molecules of the fluid that lines the alveolus, and that how they reduce the attraction forces of the molecules of the fluid lining the alveolus, and that how they reduce the surface tension and prevents the alveolus from getting collapsed. The details mechanism is given here. They reduce surface tension of fluid lining the alveoli by not dissolving uniformly in the fluid, because the fatty acid tail or the lipid soluble portion will not dissolve, but they will spread over the surface of the water, and that's how they will reduce the surface tension and attraction forces of the molecules of water or fluid lining the alveoli. Now the functions of surfactant is given here. They reduce surface tension of fluid, I have previously mentioned, and that's how they promote the stability of lung alveoli in low lung volume. That is very important, and that explanation of this can be given by a law that is called the law of Laplace, that is P is equal to 2T by R. Here P is the pressure in the alveoli or interalveolar pressure, and T is the surface tension between the fluid molecules, and R is the radius of the alveoli. So if any instances the radius of the alveolus is decreased, and if alongside with it the surface tension is not decreased, the pressure will be increased, because the radius because the surface tension, the law is like that 2T by R. So naturally if the radius is decreased while the surface tension remains constant, the pressure will be automatically increased. So if the pressure is increased, that will collapse the alveoli. So if we want the alveoli to remain in their normal position or prevent them from the collapsing, so we must have to decrease the T or the surface tension while the radius is decreasing. and that's how we can prevent the pressure of the alveolus to be increased, and that function is performed by surfactant when during expiration the radius of the alveolus is reduced, because no inspiratory signal is coming. So the automatically the mechanism of you can recall the mechanism of expiration. While the uh, intra-alveolar pressure will be increased because the radius of the alveoli will be decreased, because the interpleural pressure will be increased. So this increased interpleural pressure during expiration will compress the alveoli. So if any instances we cannot reduce the surface tension on T, the pressure will be exceeded so much that it will actually collapse the alveoli. So that is prevented by surfactant, which reduce the surface tension of the alveolus or the fluid lining the alveolus, and that's how they prevent the increase of the intraalveolar pressure during low lung volume, that is the expiration phase of respiration, and that's how they promote the stability of lung alveoli. And they also prevent the pulmonary edema by keeping the alveoli dry, because pulmonary edema will only occur if the interpleural pressure become positive, and they reduce the effort required by respiratory muscle to expand the lung, because if the alveolus got collapsed during expiration, the efforts that is given by respiratory muscle will be so much to expand the lung during inspiration. So that is prevented by surface tension, that is prevented by surfactant, which reduce the surface tension, and that's how they prevent the collapsing of the lung alveolus. Now, if any instances the surfactant is not secreted properly or cannot function properly, what will happen? The clinical condition that happens in the absence of surfactant is called hyaline membrane disease. The surfactant actually begins to be secreted during the 6th to 7th month of intrauterine life from the type 2 alveolar epithelial cell. So, if any infant if they born before this age, there is insufficiency of surfactant in their lung. So the surface tension of the fluid lining the alveolus will be so much increased, so it will actually collapse the lung, and it is called the infant respiratory distress syndrome or hyaline membrane disease. So this is the mechanism. If the baby is born before the age when the surfactant begins to be secreted, the surface tension of the fluid lining alveoli will increase, and it will increase the collapsing tendency about 6 to 8 times, and alveolus are actually collapsed in many areas, especially during expiration. As we if we can recall the law of Laplace, that P is equal to 2T by R. So R means radius. The infant alveolar is much more smaller than our adult alveolus, so the radius of their alveolus is already smaller than us, and in if any case the surface tension also is increased because of the absence of surfactants. So you can imagine what will happen, because their intra-alveolar pressure will be so increased that the alveolus would got collapsed. And when the alveolus got collapsed, there will be retention of fluid, because fluid has always the tendency, fluid or gaseous substance or solid substances, any substances has the tendency to come from high pressure zone to low pressure zone. So if the alveolus got collapsed, the pressure in the alveolus there will be no pressure in the alveolus, because there will be no air. So the fluid will enter from outside of the alveolus into the alveolus, so there will be retention of fluid, and that is called edema. That is the mechanism of pulmonary edema, and there will be severe respiratory distress. This is called hyaline membrane disease or infant respiratory distress syndrome. Now this same collapsing tendency or collapse of the alveoli can happen in adult. In that case we call it atelectasis, and this atelectasis may occur in the localized area of lungs or in the entire lung if there is total obstruction of the airway or lack of surfactant or fluid lining the alveoli. If any instances After birth or in adult life, the cells that secretes the surfactant, all of them become dysfunctional. So there will be same condition that we have previously mentioned in regarding the infant respiratory distress syndrome. There will be retention of fluid, and there will be pulmonary edema and severe respiratory distress because of the collapse of the alveoli. Now, the compliance of lungs. Compliance means the extent to which lungs will expand for each unit increase in the transpulmonary pressure. That is the compliance of lung, and the total compliance of two lungs together is about 200 ml per centimeter of transpulmonary pressure. That means per centimeter increase of transpulmonary pressure will allow the lung to be expanded to about 200 ml. And the factors that determines this lung compliance is the elastic force of the lung tissue. It's actually opposing factor that prevents the compliance of the lung, because the elastic force of the lung tissue always tries to pull the alveoli away from the chest wall or to recoil. That is called the elastic recoil tendency. So if any instances the elastic force of lung tissue is increased, that is the elastic force is increased, it will decrease the lung compliance, or vice versa. That means if the elastic force of the lung tissue is decreased, it will increase the lung compliance, which happens in some obstructive airway disease like COPD, where there is destruction of the elastic structure of the lung because of the activation of elastase enzyme, which actually destroys the lung's parenchyma elastic fiber. So this elastase enzyme can be activated by nicotine that is present in tobacco or smoking. So COPD is much more common in smoker because the nicotine of the cigarette smoking activates this elastase enzyme. So this decreases the elastic fiber of the lung alveoli. So they decrease the elastic force and increase the lung compliance. And also another factor is elastic force caused by the surface tension of the fluid. It gives about 2/3 of the elastic forces. So it increases tremendously in absence of surfactant, because the surfactant reduces the surface tension. So if there is absence of surfactant, there will be automatically increase in the surface tension, and there's also that will also increase the elastic force. So there will be decreased lung compliance. Now the lung volumes or the pulmonary volumes. So first comes the tidal volume, that is the amount of air that is inspired or expired quietly in each normal breath, that is about 500 ml. And in after quiet inspiration, if we have to inspire more amount of air, if our metabolic demand is increased, if any instances during exercise our metabolic demand is increased because workload is increased, so there is extra need of oxygen. So in that case, the extra amount of oxygen cannot be served by the normal quiet inspiration, so if you have to inspire more. So this is the extra volume of air that we can inspire over and above the normal tidal volume. So that means we can inspire maximum about 3000 ml of air if we inspire forcefully. And expiratory reserve volume, that is same, that is the maximum extra volume of air that we can expire after a forceful expiration after a normal tidal expiration. In normal tidal expiration, we can expire 500 ml of air, but if we expire forcefully, we can expire extra 1100 ml of air. And the residual volume of air I have already discussed. That is the volume of air that will be remaining in our lung alveoli even after the most forceful expiration, that is about 1200 ml of air. Now comes the lung or pulmonary capacities. There is a specific equation to calculate the specific capacity. First comes the inspiratory capacity. It is the amount of air that a person can breathe in beginning at normal expiratory level and distending the lungs to the maximum amount. So if we sum it the tidal volume, with the inspiratory reserve volume, we will get the total inspiratory capacity that is 3500 ml. Now the functional residual capacity, it is the amounts of the air that will remain in the lungs at the end of normal expiration. So to calculate this, we have to sum up the residual volume with the expiratory reserve volume, that is 2300 ml, and total lung capacity, it is the maximum volume to which the lungs can be expanded with the greatest possible effort. So it is the vital capacity plus residual volume, that is about 5800 ml, and in some healthy adults it can be 6000 ml. So now comes the vital capacity, the most important lung capacity. It is the maximum amount of air a person can expel from the lung after first filling the lungs to their maximum extent and then expel into the maximum extent. So I have previously mentioned that the extra amount of air that we can inspire after a normal tidal inspiration is called inspiratory reserve volume, and the maximum amount of air or the extra amount of air that we can expire forcefully after a normal tidal expiration is called expiratory reserve volume. So if we summate these three values, that is the tidal volume, inspiratory reserve volume and expiratory reserve volume, we will get our vital capacity, that is about 4600 ml. And all these pulmonary volumes and capacities are about 20 to 25% less in women than men because of their less diameter of their chest cavity and the less strength of the respiratory muscle in women, because the strength of respiratory muscle depends on protein. Not only respiratory muscle, rather all the muscles are dependent on the protein, and the testosterone that is present in men has a protein anabolic effect, while the estrogen in female doesn't have this much capability of protein anabolism. So the strength of respiratory muscle is also increased in men, and the diameter of the chest cavity is also increased, also more in male. So the lung volumes and capacities are also more in male. This is a spirogram showing the different inspiratory or expiratory volumes and capacities. So first, if we can see that this is the tidal volume, that is 500 ml. Okay, so the difference between of each mark is 1000. So if we can imagine this for 500 ml, then after getting this 500 ml of air, if we can inspire maximally, we will get extra amount of air, that is called the inspiratory reserve volume, and that is about 3000 ml. So that is our inspiratory reserve volume. After tidal inspiration, we can get these 3000 ml of air if we inspire maximally or forcefully, that is from 3000 to about 6000, that is total 3000 ml of air. And if we summate this tidal volume with the inspiratory reserve volume, we will get the total inspiratory capacity, that is from here to there 500 plus 3000, so that is total 3500 ml of air. Now comes the expiratory reserve volume, that after a normal tidal expiration we can exhale extra 1100 ml of air, that is the expiratory reserve volume, and that is the expiratory reserve volume, and the 1200 ml of air will remain in the alveoli always, even after a most forceful expiration. So if we summate these two values, expiratory reserve volume with the residual volume, we will got our functional residual capacity, that is 2300 ml. Now the vital capacity. Vital capacity is tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. So that will be our vital capacity, that is 3000 plus 500 plus 1100, that is 4600 ml. And the total lung capacity is the summation of vital capacity with the residual volume. So 4600 plus 1200, that is the 5800 ml of air. Now the importance or significance of vital capacity. It performs as an useful lung function test which will give us important information regarding the strength of respiratory muscle, as it is dependent on the strength of respiratory muscle. It also will indicate the efficiency of lungs in the act of ventilation. The more the vital capacity, more will be the efficiency of lungs, and it gives us an idea about the progression of pulmonary disease. If in instances the vital capacity keeps continuously decreasing, that means the prognosis is poor, that means the disease is progressing very rapidly, and vice versa. Now the factors that regulate the vital capacity. First one of them is the strength of respiratory muscle, uh, and the lung compliance, that means they are proportionate. That means if the strength of respiratory muscle increase and the lung compliance is increased, the vital capacity will also increase. And elastic work and airway resistance, these are inversely proportionate. That means elastic work means the work that has to be performed to against the elastic forces. So if the elastic forces increases, that means the elastic work also increases, so it will decrease the vital capacity. And airway resistance, if the airway resistance increase, the vital capacity will decrease, and vice versa. And some other factors alongside with the regulating factors affects the vital capacity. They are the age. Vital capacity is more in young people because their strength of respiratory muscle is more in comparison to old people. And sex, it's more in male, and the causes behind it has been previously mentioned. And surface area, proportionate to surface area, the more the surface area, more the space for the air to enter into the space. And body build, good body build will give a good strength of the respiratory muscle, and more surface area for the air to enter, so the vital capacity will naturally increase, and vice versa. Now the posture, it is low in lying position because the diaphragm in lying position goes little up, and also sorry and venous return will also increase in lying position. So it will congest the chest and decrease the chest space, space in the intrathoracic space, so it will decrease the vital capacity. And it's high in standing position because the diaphragm will go down, and also the venous return will decrease, so there is increase in intrathoracic volume, so there is more space for the air to enter. And it's highest in sitting position or in slightly reclined position. And anatomical build of the chest, in some chest deformities like barrel shaped chest or pigeon chest or kyphosis, there is decrease in the intrathoracic volume or intrathoracic space, so naturally the vital capacity will decrease. Pregnancy, because of the increased side of the gravid uterus, it will push the diaphragm upwards, so there will be decrease in intrathoracic space, and less space for the air to enter. Physical training will increase the strength of the respiratory muscles, so vital capacity will increase. Disease of lungs and pleura will decrease the vital capacity, and congestive cardiac failure also decrease the lung compliance, so it will decrease the vital capacity as well because of pulmonary congestion and retention of fluid, that is the pulmonary edema. Now there are a group of tests by which we can get information regarding our how well our lungs are functioning, that are collectively known as lung function tests. And there are different tests to assess the different mechanics of respiration or different aspects of respiration. So if we have to assess the ventilation or mechanics of respiration, we can go for spirometry. Through spirometry, by spirometer, we can measure all the capacities and volume except for the residual volume and the two capacity that is the functional residual capacity and total lung capacity. Because in the calculation of these two capacity we need residual volume, and this amount of air we cannot expire this even with our maximum expiratory effort, and spirometer requires the expiration and inspiration of air for it to record the volume of air. So if we cannot expire the air with our maximum amount of air, the spirometer will not be able to record it. So the residual volume and two capacities which requires for their calculation, residual volume cannot be directly measured from the spirometry, but they can be calculated because we know there is a fixed amount of residual volume for all, that is 1200 ml. And that is we can also go for the dynamic pulmonary function test, that is the pulmonary function test or the volume of air that are dependent on time. So that is the forced expiratory volume in first second, that is the ratio of forced expiratory volume in first second, and the forced vital capacity and peak expiratory flow rate, maximum breathing capacity and minute respiratory volume. And measurement of oxygen consumption and carbon dioxide production can be measured by nitrogen meter. Carbon dioxide production can be also measured, and measurement of dead space can be done by nitrogen meter and Bohr's equation. To assess the efficiency of gas exchange at alveolar level, we can go for the diffusing capacity of oxygen and carbon dioxide by blood gas analysis, and ventilation perfusion ratio. There is a lot of spelling mistake in this slide. And physiological shunted pulse, we can also measure this. An assessment of the efficiency of lung in relation to exercise by the treadmill exercise test, and assessment of chest expansibility by measuring TEP. This is a diagram of typical spirometer, analog spirometer, but these are not nowadays used. Nowadays we use digital auto spirometer. This SVC, that means slow vital capacity. The maximum amount of air inspiration and maximum amount of air expiration can be done either slowly or either it can be inspired or expired forcefully. So in that context, it will be regarded as either slow vital capacity is if the maximum amount of air is inspired or expired slowly after tidal volume of air inspiration or expiration, and if the same amount of air, that is the maximum amount of air, is inspired or expired forcefully after normal tidal inspiration expiration, we will call it forced vital capacity. In clinically, forced vital capacity plays a more important role rather than the slow vital capacity, and the fraction of vital capacity or the fraction of the air that will be expired during the first second of forced expiratory maneuver is called the forced expiratory volume in first second. That should be more than 80% of total forced vital capacity. Now, why we will go for this lung function test and how will help us in diagnosis of different types of lungs disease. There can be of two types of lung disease or airway disease. Either they can be obstructive or they can be restrictive. Obstructive means that there is a obstruction in airways, and restrictive means that there is no obstruction in the airway but lung itself is restricted from performing its action. It may because of some inflammatory process. Chronic inflammation leads to formation of scar tissue or fibrous tissue in lungs, and this tissue uh, don't allow the lungs or hardens the lungs or don't allow the lung to get expanded, so that restricts the lung function. That's how it name has come, restrictive lung disease. So in both instances, the forced vital capacity will be decreased. In obstructive lung disease, because as there is obstruction in airways, the normal amount of air will not enter into the lungs, because the passage through which the air has to enter is now obstructed. And in case of restrictive lung disease, the airway is not obstructed. Air can enter in the air passages, but it cannot enter into the lung alveoli properly, because the lung alveoli itself is now hardened, or it cannot become expanded. So the forced expiratory volume in first second, it should be normally more than 80%. In this forced expiratory volume in first second is more decreased in obstructive lung disease in comparison to restrictive lung disease, because expiration is mainly dependent on the diameter of the airway. So as the airway obstructive disease has got problem in their airways, so there will be more decreased in the forced expiratory volume in first second. And is in the case of restrictive lung disease, the abnormality is in the lungs, not in the airways. So the expiration will not be affected so much like the obstructive lung disease. So the FEV1 may remain normal or slightly decreased. So the FEV1 FVC ratio will be more decreased in case of obstructive lung disease, as the FEV1 is normally more decreased in obstructive lung disease in comparison to FVC. So the ratio will be more decreased in obstructive lung disease, and as the FEV1 remains normal or slightly decreased in restrictive lung disease. So as the FPC, if the FPC and FEV1 both decrease proportionately, then the FEV1 FVC ratio will remain normal. And if the FEV1 is slightly decreased, FEV1 is slightly decreased, but FVC is more decreased in comparison to FEV1. So the FEV1 FVC ratio can actually increase. And cause of obstruction may be in the air passages, because of most common obstructive airway disease COPD or asthma. And in restrictive lung disease, lung is fibrous, rigid, and airway is normal. So there is no problem in expiration, because the expiration is mainly dependent on the diameter of the airway, but there will be problem in inspiration, because the alveolus has got rigid, so air cannot enter into the alveolus properly during inspiration. And if we can inspire air normally, but we cannot expire air normally, so it will actually traps the air in our alveolus. That is called air trapping. So because of this, the residual volume will be increased in obstructive lung disease. The total lung capacity and functional residual capacity will be also increased, because in calculation of these two capacity, we require residual volume. If the value of residual volume is increased, so automatically the value of total lung capacity and functional residual capacity will increase. And as in restrictive lung disease, the problem is in the alveolus. They have got rigid, so air cannot enter properly in the alveolus during inspiration. So the residual volume of air will be automatically decreased in restrictive lung disease, and so will happen in case of total lung capacity and functional residual capacity. And that is all. Thank you very much.